So, ladies and gentlemen, thank you very much for joining us. We have a wonderful guest who has come back for a second time, and this is Kathleen Vollman. And Kathleen is a critical care clinical nurse specialist, educator, and consultant from the US. She has published and lectured nationally and internationally on a variety of topics, including critical care, pulmonary medicine, and sepsis.
I'm really excited to be with you again and to talk about really this concept of do no harm, going beyond the guidelines to eliminate CAUTI and CLABSI. Whenever I talk about fundamental nursing care, I really like to discuss this concept of where did do no harm come from? Now we know a lot of our national and international safety initiatives have the phrase do no harm. Our physician colleagues have it in their Hippocratic Oath. Here it is for nursing. Florence Nightingale wrote, "It may seem a strange principle to enunciate that the very first requirement in a hospital is to do the sick no harm." So there's no question in my mind, our advocacy role equals safety. So if you ask the average nurse about CAUTI, CLABSI, pressure injuries, doing their Braden risk score or their Waterloo risk score, they'll look at it as that's something I need to do because it's something the hospital is working on or a regulatory agency is measuring versus this is what I own as a professional registered nurse to prevent harm. So when we look at the major activities that we do to protect the patient from bad things happening during our shift, they really revolve around two things: a broadened definition of hygiene and mobility. And I got to tell you, almost 40 years as a critical care nurse, those are not sexy interventions. They've got to compete with the latest balloon pump, the new Impala, the jetpack for the transplant patients, the new ventilator strategy. And so I created a term to try and compete in sexiness with all of those activities to focus on what we need to own. And that term is called interventional patient hygiene. Evidence-based strategies for reducing the patient's risk for CAUTI. I think it's important to understand that the urinary catheter itself is harm outside of just an infection. An infection is one component, but if a patient has a catheter, they don't move. They tend to stay in bed. They have a greater chance of pressure injuries. They're immobile. They could develop DVT. When they try to get out of bed to go to the bathroom, they're weak and they can tend to fall. And so I want you to look at this as more of a total patient safety issue versus just a CAUTI. When we talk about optimizing alternatives, one of the important components is literally getting people up and toileting them, but also if that is not capable because of the patient's condition, evaluating the bladder scanner and really thinking about straight cath or using external catheters. For those of you that may not seen this, we now have female external devices in the United States. They look quite bizarre, and most nurses are a little kind of about them until they've actually utilized them. So you can see where they are placed, and they literally hook up to a suction catheter. Now, you're worried maybe that tissue would be suctioned. No, the way the suction works, if somebody would happen to move it up to 250 millimeters of mercury, all it would do is feel more breezy. So it wouldn't actually harm any tissue. So I think that's important for you to know. So it gets placed between the labia and the urethral opening and sort of gets tucked in there. And when the female voids, it collects in the suction catheter. So one of the questions to ask during multidisciplinary rounds literally is, are we responding hourly to the patient's output? And if we're not, then we need to consider the alternatives. And one of the things the science is telling us, it's inappropriate to use urinary catheters simply because the patient's being cared for in the intensive care unit. And that's a change that's happening. And one of the things that we do know, and I know when I was in my training and for a good portion of my career, foul smelly urine, cloudy urine, sediment in the urine was really a potential indication to get a culture. Those are not triggers in catheterized patients because the catheter itself colonizes. You've got to connect it with symptoms. Even having white blood cell count or nitrates in there is not an indication that it's an infection unless you connect it to a symptom in the patient. So another component that goes to this journey is how we bathe patients. We know that basins are a source of contamination. This was a large multi-center study where they looked at over 88 hospitals, where they examined over 1,100 basins. 62% of the bath basins were contaminated. 45% of that contamination was with gram-negative bacilli. 35% of it was with VRE. And so the basins are a bug fest. So we'll continue with central line, and there are some crossovers. Just to talk about the potential sources, literally the hub itself, where we're at the skin. There are some sources that come internally in the body itself, but I circled the ones that are the most significant. So let's take a look at what goes beyond the bundle. And one of the big things is dressing disruption. So in the large CHG disc and dressing studies, they also simultaneously studied dressing disruption in a secondary analysis. So they had over 1,400 patients, 11,000 dressing changes, with 67% of them occurring before the planned date. So what does that mean? Well, the number of dressing disruptions is significantly related to the risk of colonization on the skin around the catheter. In the second dressing disruption, the risk of infection increased threefold. In the final dressing disruption, it was a 10-fold increase. So one of the things to look at is doing evaluations as to how frequent are you changing it before the 7 days, and are there strategies to keep the dressing in place better? The next beyond is bathing. Literally, guys, a traditional soap and water basin was an independent predictor of a bloodstream infection. What is the data showing us? The data is clearly showing that bathing with chlorhexidine is superior to soap and water in reducing bloodstream infections, and this is a meta-analysis.